Today we will talk about the extremely low birth weight infant, which is a very important neonatologist problem, and we have to deal with these children every day. The plan of my presentation is to first state some introductory remarks and short definitions about this problem. Then we will talk about predictors for survival and outcome of this group of patients. I will explore some of the specific problems of the extremely low birth weight infants, which focuses on respiratory distress syndrome and bronchopulmonary dysplasia as one of the most frequent early and late problems of this group. And then I will present you with the results of our study of extremely low birth weight infants. Prematurity is defined as birth before 37 weeks of completed gestation. Reports state that about 12% of infants are born premature in the United States, whereas in Europe, the prevalence is between 5 and 11%. In Croatia, where I work, the percentage is 5 to 6. Preterm infants are at an increased risk of neurodevelopmental impairments and respiratory and gastrointestinal complications. Preterm birth is now regarded as syndrome resulting from multiple causes, of which most important are infection and inflammation, as well as uteroplacental ischemia or hemorrhage. Prematurity is related to increased perinatal mortality and morbidity. Current minimal age of viability is considered to be 22 to 23 gestation weeks, with dispersed reports of survival earlier than this estimated gestational age. Extremely low birth weight infants are defined by birth weight of less than 1,000 grams. They are youngest of the premature newborns, typically born at 27 gestation weeks or younger. Attention has turned to the improvement of the intact survival rate of these infants, particularly for those born at the frontiers of current perinatal medicine. Survival rate to hospital discharge of about 80% have been reported in developed centers in Canada, USA, and Japan. Developed centers report on increased survival rates also for the infants born at 23 to 24 gestation weeks. Significant variability in survival rates has been observed in resource-limited centers. In the literature, the predictors of survival and outcome in this group are explored. And according to literature, positive predictors are older gestational age, higher birth weight, female gender, singleton birth, and antenatal steroid use, as well as delivery by cesarean section. A significant correlation of cesarean section delivery with outcome has been observed in studies with the higher share of emergency cesarean section in survivors, pointing out that cesarean section is indeed a protective mode of delivery. However, indication of a cesarean section before 24 weeks of gestation is a matter of worldwide debate, and to answer this question, a nationwide survey is needed. Negative predictors, on the other hand, are vaginal delivery, non-vertex presentation, placental abruption, and fetal growth restriction. The mortality rate has significantly diminished with improved neonatal technologies, exogenous surfactant preparations application, and better understanding of pathophysiology of this group of patients. However, the proportion of surviving infants without sequelae, such as chronic lung disease, cognitive delays, or neurosensory deficits, has not improved as noticeably. I will talk in this presentation I will talk of respiratory distress syndrome as one of the first pathologies that we encounter while dealing with this patient, and I will present the newest recommendation as for treatment of this syndrome. We will talk about thermoregulation, which significantly improved neonatal outcomes during the first minutes and hours of life. And then we will turn to one of the most important long-term consequences of extremely low birth weight infants, which is bronchopulmonary dysplasia, which can lead to certain difficulties in neurodevelopment. Neonatal respiratory distress syndrome is caused by surfactant deficiency, and this surfactant deficiency causes decreased pulmonary compliance, alveolar hypotension, and discrepancy between pulmonary ventilation and perfusion. This is the leading cause of admission in neonatal intensive care units, with a mortality rate of 50% in preterm infants. RDS was recorded in 80% of babies born at 28 weeks gestation, and in 90% of those that are born at 24 weeks gestation, according to Vermont-Oxford Network data for 2017. To state the diagnosis, or to make the diagnosis of respiratory distress syndrome, we have some laboratory examinations at hand, as well as methods such as chest X-ray and lung ultrasound. From the laboratory tests, the gastric aspirate test is a laboratory test with a reported sensitivity of 100% and specificity of 92% for the diagnosis of NRDS. It identifies the presence or absence of surfactants in gastric aspirates. Also, recently published studies turn to certain cytokine factors for the detection and prediction of NRDS, such as the transforming growth factor beta-1 or interleukin 6, which are, of course, costly and not useful for everyday use in the detection of NRDS, but they can be used sometimes for the detection. And what we do most is performing chest X-rays that show typical features of NRDS, such as this decreased lung expansion, air bronchograms, and dilated bronchioles. They can also use to confirm the position of the endotracheal tube. And recently, lung ultrasound has been used and explored as an accurate diagnostic tool for diagnosis of NRDS. A meta-analysis of 6 studies confirmed ultrasound. This meta-analysis compared ultrasound with chest X-ray, and they reported of a high diagnostic sensitivity and specificity for ultrasound. The European Consensus Group performed and they regularly update their recommendation guidelines for management and treatment of respiratory distress syndrome. And according to the last update, they give precise recommendation as to difference into different segments of care. They give recommendations for the prenatal care, perinatal care, and postnatal care of this syndrome. The key recommendations in the obstetric part of the care or prenatal care are to give antibiotics in cases of preterm premature rupture of membranes to delay the preterm birth, to give magnesium sulfate to the women to reduce the incidence of cerebral palsy. Tocolytic drugs are also recommended in order to delay childbirth and allow safe transport to the tertiary center or to the perinatal center. Prenatal corticosteroid therapy is recommended in all pregnancy with threatened preterm birth before 34 weeks of gestation. And the WHO recommends considering another steroid course if preterm birth did not occur within 7 days of the first treatment. As for stabilization in the delivery room, the consensus guidelines state that there should be a attempt to delay umbilical cord clamping for at least 60 seconds in order to promote placental fetal transfusion. And when we are to stabilize a baby born before 28 weeks of gestation, a plastic bag or wrap should be used under a radiant heater to reduce the risk of hypothermia. As for the pulse assessment, there are various techniques that can be used. Of the four techniques presented here, most reliable is the electrode positioning and monitoring of heart rate. This is a fast, accurate, consistent method. Continuous recording is available, and sound is also available to the team. But the problems are how to connect the electrodes to the wet skin, and it requires some additional cost and training. As for the stabilization with oxygen in the delivery room, the recommendations are also very precise. Oxygen should be controlled. An initial oxygen concentration of 30% is suitable for newborns before 28 weeks of gestation. Routine aspiration is no longer recommended. In children who breathe spontaneously, stabilization should be with a CPAP of at least 6 centimeters water. If the child is not breathing sufficiently, the lungs should be ventilated with a positive pressure of 20 to 25 centimeters water. And intubation is reserved for newborns who do not respond to positive pressure ventilation. And the babies who require intubation should be given surfactant. As for the surfactant therapy, there are various considerations, but I will just briefly go through all these considerations. First of all, if we consider whether we should give surfactant prophylactically or selectively, the literature states, and this is of course confirmed by recent large trials reflecting current practice, that there is a lower risk of chronic lung disease with stabilization on CPAP and selective surfactant administration. However, infants that are born at 23 to 24 weeks gestation continue to have a higher need for intubation during the initial stabilization. On the question how to apply the surfactant or whether to use Ensure or LISA, the Ensure technique involves administration of surfactant to an endotracheal tube with the use of positive pressure ventilation and often with premedication or sedation. During the surfactant administration, the patient is disconnected from the CPAP and manually ventilated for from 2 to 5 minutes and then extubated. The first evidence of Ensure dates back to 1994 when a randomized controlled multicenter study was performed, confirming a surfactant in combination with CPAP is the better method to reduce the need for mechanical ventilation. And these effects of the Ensure method have been widely represented in studies, and the method has been reproduced many times. However, there is a new growing evidence about the effects and successfulness of the LISA technique as well. And the LISA technique, or the technique of less invasive surfactant administration, involves administering of surfactant through a thin catheter into the trachea under direct laryngoscopy, with the children breathing spontaneously on CPAP and without using premedication or sedation. The first randomized multicenter clinical study of LISA was performed and printed in JAMA Pediatrics in 2015. According to this study, it was concluded that LISA did not increase survival without BPD, but was associated with increased survival without major complications. And it was in fact concluded that LISA can be a promising therapy for extremely immature preterm infants. And afterwards, in many studies, as well as systemic reviews and meta-analysis, it was confirmed that LISA is a protective method, and it reduces the need for mechanical ventilation and the composite outcome of death and BPD at 36 weeks. So the current state of knowledge is that LISA is the preferred route of administration of surfactant to infants who breathe spontaneously on CPAP. There are also some recent studies that question the success rate and technical quality of LISA. And this study reveals a high percentage of desaturations during performing the first attempt of performing LISA technique. So if we are to summarize the surfactant, the method of application of surfactant, we should say that endotracheal intubation and mechanical ventilation is reserved for the extremely immature preterm infants, and it should be as short as possible. Insura is a technique with a proven effect, but sedation is used. LISA is a promising new method that does not include sedation, but it's still operator dependent and depends on the technical conditions. Laryngeal mask airway can be used for administration of surfactant, but its use is limited to the relatively mature preterm infants. And pharyngeal installation and nebulizing surfactant are still under investigation. As for oxygen supplementation outside stabilization, there were 5 randomized control trials comparing lower with higher target saturation for the extremely immature preterm infants in order to find a balance between the negative effects of excessive oxygenation, such as retinopathy of prematurity or bronchopulmonary dysplasia on one side, and the negative effects of low-grade hypoxia, such as increased mortality or poor neurodevelopmental outcomes on the other side. A significant difference was found in the risk of death between groups between these two groups in favor of the higher saturation target. So trials give no reason to prefer lower saturation targets below 90%. And therefore, in preterm infants, the saturation target should be kept between 90 and 94. And to summarize on the strategy of non-invasive respiratory support and mechanical ventilation, I will just shortly state that CPAP with early surfactant is considered the optimal management of RDS, and targeted volume ventilation and shorter duration of mechanical ventilation are used as a method of invasive respiratory support in the most immature infants. Thermoregulation is also very important in the first hours, and association between hypothermia and adverse neonatal outcomes have been found. The relationship between admission temperature and adverse neonatal outcomes was U-shaped, and the lower rates of adverse outcomes were related to input temperatures of 36.5 to 37.2 degrees centigrade. So the recommendations state that the core temperature should be kept between 36.5 and 37.5 degrees at all times, and that we should use plastic wraps or bags under radiant heater at admission to the NICU for the extremely immature infants to obtain better results or to obtain less adverse neonatal outcomes. And bronchopulmonary dysplasia was traditionally considered an oxygen and respirator-mediated injury related to prematurity. But since the now gentler ventilation techniques are applied, it is now limited to newborns that are born with less than 30 weeks gestation and with a birth weight of less than 1,200 grams. According to the new revised definition of BPD developed by the National Institute of Child Health and Human Development in 2001, the disease is categorized as mild, moderate, or severe solely on the basis of oxygen dependency level at 36 gestation weeks. It is important to note that infants with BPD are found to have higher rates of adverse neurodevelopmental outcomes and cognitive impairments in early childhood, and that they were recognized with growth impairment and academic difficulties at school years. And now I will present you with the results of our study of extremely low birth weight infants. The study was performed at the University Clinic for Gynecology and Obstetrics in the Clinical Hospital Center Split. The aim of our study was to present a global approach to care for extremely low birth weight infants, focusing on issues of primary concern to them. We tended to show the outcome of infants of extremely low birth weight at the Clinic for Gynecology and Obstetrics Neonatal Department in a period of 2 years to compare the outcomes of these infants with the available literature data, to compare the impact of some variables on the outcome, and for the survivors to analyze the incidence of complications. The study design was retrospective analytical and included birth records of extremely low birth weight newborns for the period of 2 years. The cohort consisted of 41 examinees with a birth weight of less than 1,000 grams. A computer database was kept for purposes of clinical audit. The following data were retrieved from the database: maternal data, such as parity, gravidity, antenatal steroid use, syndrome of intrameiotic infection, pre and perinatal antibiotics. Then aspects of antenatal care, such as preeclampsia, gestational diabetes, and intrauterine growth retardation, and mode of delivery. Also, infant data were retrieved. The infants were divided into or stratified into two major outcome groups: survival or death. Gestational age as well as birth parameters were noted, and first minute Apgar scores. Also, we extracted some relevant clinical findings such as perinatal infection, sepsis, intracranial hemorrhage, patent ductus arteriosus, and so on. And we also extracted from the database relevant laboratory findings such as C-reactive protein or hematological status. And all these variables were compared between the two major outcome groups, survival or death. Statistical analyses were performed using SPSS for Windows. We explored the categorical variables as well as quantitative variables. Testing of significance was performed using Fisher's exact test and Mann-Whitney U test, and the results were considered significant if probability value was below 0.05 for standard significance or less than 0.01 for high significance. And according to the results of our study, the infants were divided into two major outcome groups, survival or death. The study group included 41 infants with birth weight of 500 to 999, of which 51% were male and 49% female. The median gestational age of our group was 26. The median birth weight was 780 grams, and the median head circumference was 24. The infants, there weren't any statistically significant difference between the groups according to gender. The infants that were born, the infants in the surviving group had a median gestational age of 4 weeks higher median gestational age than the infants in the group that expired. Also, the median birth weight of the surviving group was by 140 grams higher than the median birth weight of the children in the group of deaths. The Apgar scores were higher by 2.5 in the group of the surviving children. And as for cesarean section delivery, It was observed that the share of emergency cesarean section was 2.7 times higher for the group of survivors. We did not find any statistical significance for all other explored variables regarding to parity, maternal health, or prenatal and perinatal therapies applied. And as for the laboratory parameters between the two major outcome groups, CRP was significantly higher in the group of surviving infants. The levels of leukocytes and thrombocytes did not significantly differ between the groups. However, erythrocytes and hemoglobin level were significantly higher for the group of survivors as compared to the group of deaths. And glucose level was by 3.9% higher in the group of deaths as compared to the group of surviving children, suggesting that glycemic regulation is important in the survival and outcome of these children. We explored some late morbidities in these groups of children as well. We found a low incidence of bronchopulmonary dysplasia of 7% in our group. We also found a high percentage of later onset infection in the group of, it was present in 73% of the children. And it was treated with backup antibiotics according to the finding of the microbiological isolate. Intraventricular hemorrhage was present in 29% of the children without significant difference between the groups. And PVL grade 3, which is associated with poor neurodevelopmental outcome, was found in only one patient of the group of deaths. Retinopathy of prematurity that required application of anti-VEGF treatment or laser photocoagulation was present in 17.1%. This low rate of adverse outcomes we suspect that it is because of the small study group, and that additional patients need to be included in the group in order to conclude whether certain practices performed at our center, particularly connected to the method of ventilation of these infants, has important impact on the survival rate and on the late outcomes. And these are microbiological isolates that are mainly present in our group. I will just stress that we only had one patient with candida sepsis in our group, and we suspect that this is because of the department's policy for regular candida prophylaxis with fluconazole. And to conclude, according to the results of our study, positive predictors of outcome were Apgar scores at 1 minute, cesarean section delivery, higher birth weight and bigger head circumference, beta glycemic regulation, and beta hematological status. And at the end, the mortality rate of these infants has significantly diminished with improved technology and improved neonatal practices. However, there are still many issues to be covered for optimal complete approach to these patients. Efforts have to be made to reduce not just the immediate but also the long-term consequences. Survival of extremely low birth weight infants in our center was satisfying. Strong predictors were birth weight and gestational age. Positive correlation was observed with cesarean section, beta glycemic regulation, and better hematological state. But we have to take effective steps for prevention of extreme prematurity, and we have to keep appropriate databases in order to enable adequate long-term follow-up of these children. And by this, I thank you for your attention.